Hi, guys. My name is Dr. Dakesh Patel, and I'm part of the GI Alliance, and I'm joined here with Kate Scarlata.
That's right. I'm Kate Scarlata. I'm a registered dietitian with GI expertise, and we're here at GI ReConnect, both speaking at the conference, and wanted to talk to you about carbohydrate intolerance and malabsorption and maldigestion today.
Absolutely. And, we recently worked on a paper that was just published in the American Journal of Gastroenterology in April. And it was entitled Demystifying Carbohydrate Maldigestion. So that's a little bit of what we're going to be talking and discussing about today. So I wanted to just, start off by saying these symptoms of gas, bloating, abdominal pain, diarrhea, they're incredibly common. And they're often very disruptive, and trying to figure out the root of these symptoms can often feel like, trying to solve a complex puzzle. And one piece of that puzzle that often gets overlooked is carbohydrate maldigestion.
That's right. And those symptoms of gas and bloating, abdominal pain sometimes really can almost mimic IBS. So it can be confusing because we see a lot of IBS patients, and how many of those is carbohydrate intolerance part of their picture?
Yeah, no, absolutely. I think, I want to dive into what you just said there, but I want to paint the picture in terms of carbohydrates. It is, more than anybody else, it is a big chunk of the calories that we consume in the West here. According to this USDA trial from 2019, they make up nearly half of our calories. And that in itself is not bad, but it's a source of those carbohydrates that's bad. So in that same year, Harvard School of Public Health showed that 42% of those carbohydrate calories are coming from refined grains and added sugars, and only 9% are coming from whole grains and whole fruits. So the problem here is that a large chunk of the carbohydrate calories we're consuming are coming from added sugars.
I know, it is a problem, right? And for many people, these carbohydrates can really trigger symptoms. So why is that?
Yeah, well, I think that the reason why that is that, first of all, to answer that question, we have to go back and we have to see how carbohydrates are actually digested, right? So to put it, briefly, when we take in, carbohydrates, which are essentially just, long chains of glucose, right? When we're taking that and consuming them, they're getting digested in your stomach and your GI tract. Ultimately, it boils down to these digestive enzymes of sucrase, of maltase, isomaltase, and lactase. And the job of these enzymes are to break down big sugars into little, small, digestible, absorbable sugars, right? And if these enzymes don't do their jobs, that's when we have an issue, right? Because now you have these big sugars that end up in your colon, and they get fermented by the 100 trillion bacteria that live there. And that fermentation process produces a lot of the gas, the volatile gases of hydrogen gas, carbon dioxide gas. That's what contributes to a lot of the gas, the bloating symptoms. And certainly certain gases like methane can tie to constipation, hydrogen sulfide, growing body of literature is tying that to, diarrhea and urgency. But that's often why these patients have these symptoms.
Absolutely. And they also have osmotic activity, right? So these small sugars get malabsorbed, and they drag in water into the gut, and that can lead to that, diarrhea scenario, right?
Absolutely. No, 100% true. And what's interesting, though, let's back now to what you were saying earlier about maldigestion, malabsorption, and intolerance. Okay, we talked about this in our paper. These terms are used interchangeably, but maybe they shouldn't be, because they have each distinct definitions. So maldigestion refers to breakdown and a failure of that breakdown. So we talked about enzymes being responsible for the breakdown of big sugars into small sugars, but when you have a failure of that breakdown because there's an enzyme deficiency or is a dysfunction involving that enzyme, that's called maldigestion. Malabsorption is when that big sugar is ending up in your colon. Right?
It's not getting absorbed.
And that could be, it's not getting absorbed because of the enzyme dysfunction or deficiency, but also could be an issue with the intestinal transporters that are required to take these small molecules of glucose, fructose, galactose, and transport it through the enterocytes so that they can get absorbed into the body and be utilized for energy, right? And so either way, if you have an issue with the transporters or the enzymes, the bottom line is that sugar is not getting absorbed. So that's called malabsorption. And then lastly, you have intolerance. Intolerance happens when you have clinical symptoms that result from the malabsorption or the maldigestion. The interesting part, though, is why do then some people that have maldigestion and malabsorption not have intolerance, right? Like you can have an enzyme deficiency and two people can have the same enzyme deficiency, but their symptoms are vastly different.
That's right. It is really interesting. And I do wonder how much the gut microbiota are involved in that. So if you have IBS is associated with sort of a dysbiotic microbiota, it's a little altered. And so those malabsorbed sugars get in touch with those bacteria and are probably triggering the immune system and doing a whole cascade of things, where someone that has a healthy gut microbiota perhaps just deals with those malabsorbed sugars
you're
without
right on
a problem.
point. And so it boils down to a complex interplay of several factors, right? One, how much sugar are they consuming? What type of sugar are they consuming? How much residual enzyme do they have? And then, yes, you're absolutely right, the unique mix and activity level of their own personal gut microbiome, because different bacteria are producing different gases, different amounts of gases. It also has to do with the structure and function of their GI tract, right? Which can, of course, influence the rate of gastric emptying and intestinal transit time. And lastly is that visceral hypersensitivity, which also can be the result of a gut microbiome, right?
Absolutely.
But that visceral hypersensitivity is huge because, if someone's volume knob in terms of sensitivity is dialed up, they're going to be sensing the gas that's produced from that fermentation that happened because of the carbohydrate maldigestion to a higher degree than maybe somebody that has the volume knob down, right?
Absolutely. They did a really interesting study in lactose intolerance in individuals with IBS, and they found that, so intolerance, again, the symptoms, and they looked at their mast cells and they could see, compared to like healthy controls, the IBS patients had, lots of active degranulating mast cells. So and mast cells are immune cells. So it was a different scenario compared to people that didn't have IBS. So, just again, describing this immune system, gut microbiota, there's lots of different things going on in different conditions, right?
And so that brings up an interesting point, because I think a lot of our viewers or listeners will say, okay, well, I see gas, bloating, abdominal pain, diarrhea all the time, and I follow the guidelines. And the guidelines tell me that if these patients have met the Rome-4 criteria and they don't have alarm symptoms, this diagnosis is irritable bowel syndrome. It's IBS.
Right.
So where does all this other stuff fit in? This carbohydrate maldigestion or exocrine pancreatic insufficiency or any of these other, mimickers, where does that fit in? Because I've already made the diagnosis. So here's my thought on this. And I'd love to see, because I haven't really said this publicly. I just thought about this today. So
hot off the press.
And excuse me if I'm wrong in this, but I'd love to get your thought on it. I think that the way I'm going to look at this is that you're absolutely right. No alarm symptoms. You have the Rome-4 criteria met. You can make that diagnosis of IBS. But then ask yourself, what's triggering those symptoms of IBS, right? And perhaps one of those triggers is carbohydrate maldigestion, right? And I feel you can have both, right? You can have this diagnosis of IBS, and then you can have the triggers, right?
Absolutely.
Because the IBS diagnosis is a lot of what we just talked about. It's the visceral hypersensitivity. It's this disorder of gut-brain interaction, right? That has also to do with the gut microbiome. But that in itself is not producing this, right? You have triggers that causes that, right? And as we discussed, just because you have the maldigestion, malabsorption, and the gas that's produced because you haven't digested the sugar appropriately, it doesn't mean they're going to get symptoms, right? They're only getting symptoms because they have this other IBS play to it, right? And I think that's how I look at it fitting in.
Yeah.
It doesn't have to be a fight between this diagnosis and that.
No,
What do you
absolutely.
think?
I totally agree with you.
Thank you.
I mean, think about it. The number one evidence-based diet therapy for irritable bowel syndrome is one in which we're looking and identifying commonly malabsorbed carbohydrates.
Yeah.
Right. So there is some level of malabsorption happening in these patients and then triggering some kind of intolerance because we put them on a low FODMAP diet. And again, IBS is so heterogenetic, right? So
Absolutely.
It's a complex condition and patients present very differently, some with constipation, some with diarrhea, et cetera. About 50 to 80% of people respond with IBS to a low FODMAP diet. So there's 50% potentially that don't. So, but in those, that carbohydrate malabsorption is absolutely part of their picture. So it just reinforces.
Degree, by the way. I mean, Satish Rao, really amazing, prominent gastroenterologist, released a paper earlier this year, and he did what they call a disaccharase assay, which is basically trying to get objective levels of each of these digestive enzymes we talked about. And he did it in symptomatic individuals with IBS-D. And what he found was that, first of all, the prevalence of those that had deficiency, 40%. I mean, it was astounding. And that's just having one enzyme, being deficient. Right. But that's a large, percentage of patients that have this, that could, and what they also found was that regardless of their symptoms, whether it's gas, bloating, or it was not predictive of which, type of sugar that was getting maldigest or the severity. And so that really tells us that, we need more objective measures to figure out. We can't rely necessarily on, patients, telling us, oh, well, I think it's this food that's causing that. I think we need more objective testing to figure out, well, this is what's going on with this level of enzyme deficiency. And it's in that paper, they highlighted that certain ethnic groups are more susceptible. Yeah. So Black Americans have more disaccharase deficiencies, particularly lactase, than other ethnic populations. Absolutely. And so when you have that, population that's presenting with these symptoms, maybe consider looking for carbohydrate maldigestion, right?
Absolutely.
And not just labeling them with a certain diagnosis and not looking further if they're still symptomatic.
Absolutely. And you can do the dissect assays, or you can, in some instances with lactose, it's pretty easy to do a dietary trial where we just reduce the lactose in the diet and see if that happens. Yeah. But, certainly if you can, those objective markers are really good. So we talked about lactose intolerance. Can we talk a little bit about some of the other, like sucrase isomaltase deficiency? And are we seeing that more? I know there's some data, so we're seeing that in IBS adult patients,
Absolutely. Right? So first of all, that's such a nuanced conversation when we deal with sucrase isomaltase deficiency because it's titled congenital sucrase isomaltase deficiency. And so when people think congenital, they're thinking, okay, well, this is a childhood disorder. And they're not wrong in that because there's a mutation that happened in this sucrase isomaltase gene. And if you inherit the same mutation from both your mom and dad, you'll be homozygous. Mm-hmm. That will mean that you will likely present, in infancy with diarrhea or failure to thrive because you are not able to break down sucrose. However, we think the majority are actually what we call compound heterozygotes, which means they inherited a different mutation from both their mom and dad. And that means that they will likely present in their 20s and 30s, and they're going to come to you and say they have lifelong symptoms of gas, bloating, loose stools, right? And it's likely that they don't have a complete absence of the enzyme. It's more likely they have reduced levels of the enzyme, and that's why they're presenting a little bit later, right? And so it can be something that, can be complicated to tease out whether at that point it's congenital or is it acquired from a secondary cause of anything that damaged the intestinal villi, whether that's celiac sprue or SIBO. Right.
That's right. So inflammation in the small intestine can lead to a decline in those enzymes because they're produced there.
Right. One point I want to make with that, that we found with the, putting the paper together is going back to lactase. Yeah. It's actually found in the tip of the microvilli.
Right.
So it's so easy for lactase levels to drop, right? Even if you have just a simple viral gastroenteritis.
Yeah.
And I think that's often why we're seeing that enzyme deficiency in isolation more so than other enzyme deficiencies. But yeah, you're absolutely right. When you have inflammation, infection, then these enzymes, which are found at the brush border, which, I'm not sure if we mentioned it earlier, but that brush border is consistent of villi and microvilli, right? And that increases the absorptive surface capacity by 600-fold, right? And so when you have damage to that area, that's when these enzymes, slough off. But the nice thing is that if you do have damage, then you repair that damage or you address the underlying root cause of what caused that damage, then the enzymes hopefully bounce back after a few months.
Right. So it might just be like a transient issue. Yeah. And we see that even with the newly diagnosed celiac disease patients, we might keep them or put them on a low lactose diet initially until the healing occurs.
Yeah.
So can we talk a little bit about diet? So we have someone that we've tested, they're not making a lot of lactase enzyme. Mm-hmm. They have intolerance symptoms. Now what?
Well, I think that, I think that's a nuanced question. I think this is where this shared decision-making comes in my opinion, right? Where you need to meet the patient where they're at. And if they're interested in dietary modifications, then that's what we should talk about. There are also enzyme replacement therapies, both for lactase and sucrase deficiencies, right? And so those can be tried. And I don't think it's a bad thing to try them first necessarily, because a lot of these patients are already on restrictive diets, whether it's gluten-free or lactose-free. And then let's say they are deficient in sucrase, then for me to say, okay, now you have to avoid sugar and starch, this is where we get things like ARFID, right? Avoidant restrictive food intake disorders. And so I think enzyme replacement therapy early on is not such a bad thing to allow them to be a little bit more liberal with their diet and avoid these nutritional, deficiencies.
Totally agree with you. Totally agree with you. From the lactose standpoint, I do find enzyme supplements are fantastic, and you can take them when you're having something that is high in lactose. Lactose is kind of in the liquid part of food. So if it's like, think of milk, it's very liquidy. Mm-hmm. If you think of cheese, that's also dairy, it's very not liquidy. So the cheese tends to be lower in lactose. Things that have a lot of milk, liquid content will be higher. So your milk, ice cream, custards, that kind of thing. So cheeses and butter, low lactose, not a problem. Don't need to take an enzyme with it. So low, not a problem. But you go out for that ice cream and you know you have lactose intolerance. You pop an enzyme before, and that can be a really, really simple diet to manage.
I was just going to say, I'm super lactose intolerant. Mm-hmm. And so one of the things that I found in the research that helps is that when you combine it with a solid, then the rate of gastric emptying is delayed. And so you're able to tolerate that better. So the point is like drinking milk with cereal, you're going to be able to tolerate that better than just
have downing it, because it's going to go just fly right into that small intestine right away. No, that's a really good point. That's a really, really good point.
You were mentioning about sucrase, I think.
Yeah, so sucrase isomaltase, again, it's definitely responsible for all of sucrose, but some of starch, 60 to 80%, and that can be variable patient to patient. I always agree, start with the enzyme. Let's just see how the patient does with that. Then we're not mucking with their diet. When we think about sucrose, I think a lot of people just think of added sugar, but this sucrose containing fruits and vegetables too, that are modified on the diet. So I'm in the camp that the most liberal diet possible is the diet we want to have for our patients.
I want to highlight what you just said there, because I think sometimes if you're not a dietitian, people think, okay, well, if I have this enzyme deficiency, I need to eliminate sugar. I need to eliminate, starch. It's not about elimination. It's about reducing the symptoms, and as opposed to eliminating all carbohydrate. That's not what we're saying, because if you start to do that, you're going to run into problems.
Absolutely. We need carbohydrates for energy. It's what fuels us. And so it's good for our brain and to keep our blood sugar regulated and to get through the day. So it's just modifying certain carbohydrates. But if you can do an enzyme first, go for that, because that's going to allow a more liberal diet. If you can't get the enzyme or there's other reasons, you want to try the diet first, then work ideally with the GI dietitian to really help you modify the diet while ensuring that you're also balancing your nutrients and getting all the food that you need.
So in terms of, fructose intolerance, there is actually a genetic component.
Right.
There's something called hereditary fructose intolerance. And it's kind of rare, not as rare as congenital lactase deficiency. That was kind of interesting.
Yeah.
Congenital lactase deficiency, going back to lactase, only 40 cases in the world, mostly in Finland, right? But obviously the majority of the world, has lactase non-persistence.
Yeah.
And that's by design because, this LCT gene activity goes down in infancy to promote weaning, right? So that makes a lot of sense. But for a hereditary fructose intolerance, it's rare. It's 1 in 20,000 to 30,000.
And no fructose at all. I mean, that's a very, very...
Well, yes. Yeah. I mean,
that's a whole different can of worms.
That's failure to thrive, right? When that presents. Absolutely. But fructose intolerance or fructose maldigestion, I should say, in adults,
common,
completely different, right? That's 1 in 3 in the IBS population, right? And even if we're talking about non-IBS patients, it's extremely common because we really can only take in about 25 grams. And correct me if I'm wrong on these numbers, but beyond that, I think what's happening is that you have these, GLUT5 receptors that kind of get saturated, and then you got to turn to other, intestinal transporters, and it overwhelms their absorptive capacity.
That's right.
And so then, we get symptomatic.
That's right.
That. Yeah.
And you think of things like high fructose corn syrup that have, more fructose. So it's beneficial with fructose absorption if glucose is present at the same time.
Absolutely.
So we look at foods that maybe have equal amounts or have more glucose than fructose. Those tend to be absorbed better. So some
because
foods
that glucose facilitates
some of the other receptors and allows it to be absorbed. So things like apples, pears, watermelon, agave syrup that's used in
I talk about this, by the way, all the time.
Very high.
I just had a spicy margarita. It was delicious. But yes, it's got agave in there.
It does.
And it's actually, if you look at this in the sense of most sugars are going to be 50% glucose and 50% fructose. Agave is 85% fructose.
Yes.
You know what I mean? And so people are like, oh, it's a healthy sugar, right? It's a diabetic friendly sugar because it's only 50% glucose. So it doesn't cause that glucose spike. But nobody talks about the 85% fructose content.
That's right.
Which if you're doing it in regular quantities can have a number on your liver. You know what I mean? That's a whole other thing, right? So fructose, too much fructose can contribute to fatty liver and downstream effects to the liver. But from a digestion standpoint, it is highly osmotic. It is the smallest, but the sweetest of the sugars.
The sweetest pulls in water. So that can cause diarrhea. So people, you have a couple margaritas. And you're like, why was I rushing to the bathroom? I must have had too much alcohol. And certainly alcohol can play a role, but it could be that agave syrup. Yeah. So I stay clear of that, actually.
Yeah, do you?
Yes, I do.
So one thing that may give some hope to those that are out there suffering from fructose intolerance is an enzyme called xylose isomaltase. And, there obviously needs to be more research on this, but it is used in the industry to, convert glucose into fructose, or I should say opposite, fructose into glucose.
Correct.
And so that, may give some hope for those that are suffering there.
Absolutely.
Yeah. So I think now we've covered the major points of lactose intolerance, sucrose intolerance, and fructose intolerance. So anything else you wanted to add?
No, just, refer to a dietitian, work with a gastroenterologist to really get to the root of these conditions, because there are things we can do both from a diet and enzyme perspective.
I couldn't agree with you more. I really want to emphasize that working with the dietitian aspect of it, our practice has, definitely adopted this mindset. So we have a GI dietitian in our practice. We're working with virtual platforms that allow this to happen. And, when we're discussing carbohydrate maldigestion, it is important that a dietitian that's familiar with the disorders of gut-brain interaction is involved, so that they can help you, make appropriate dietary choices, avoid, certain food triggers, and give you a well-balanced diet, so that you're not running into issues with nutritional deficiencies.
Absolutely.
So, well, thank you all for joining us today, and we'll see you next time.